Okay, hi everyone. I'm Claire, third-year medical student. They gave me the shift right before lunch, so we might as well talk about feeding. That's probably what you're all thinking about anyways. I'm here to talk about human milk fortifiers, the ever-changing landscape that they inhabit, and what their role is in necrotizing enterocolitis. So necrotizing enterocolitis, or NEC, as many of you are very well familiar, is a process of fulminant inflammation, dysbiosis, and rapid tissue death, which unfortunately represents a leading cause of death in our neonatal intensive care units. It usually begins within a week or two of the onset of enteral feeds and presents rather nonspecifically with abdominal distension, bloody outputs, and overall declining vital signs. For reasons that we really don't understand very well, many cases actually respond practically to being made NPO or put on bowel rest and broad-spectrum antibiotics, while other cases progress, sometimes within hours of the initial clinical presentation, to a status of fulminant intestinal necrosis with risk for bowel perforation, sepsis, necessitating a surgical emergency, and unfortunately, a high proportion of NICU surgical deaths. So my group up at MUSC is really interested in that split that you see there. What is it that makes some babies take one route and respond really well to our conservative management, while others seem to spiral very quickly to a surgical emergency? And are there variables we can identify earlier on in the baby's life or in the baby's NEC presentation that can help us stratify between these two groups? So what we found was really interesting. We first identified a demographic measurement that is present at the time of birth, which was statistically significant between our cases which later progressed to surgery or death due to NEC, and our cases which resolved with antibiotics and NPO, or medical NEC. So our surgical NEC babies actually had an abdominal circumference of about 30 centimeters compared to our medical NEC with an average circumference of 23 centimeters. Even though our surgical NEC babies were born a little bit earlier and a little bit smaller than the medical NEC group. So this suggests that not only is there an anthropomorphic measurement that may help us stratify between a baby's risk of progressing to surgery or death due to NEC, but also that there's pre-existing intestinal dysmotility present at birth in many of these babies that we're not catching. So we also identified a number of peri-event factors, or factors that are present within the first 24 hours of NEC diagnosis, many of which are externally validated by other studies. And these include things such as a really high CRP, a quick and rapid drop in platelets, positive blood culture, and the need for inotropics or intubation. But what we're missing on this screen so far is anything modifiable. And we're also missing a huge chunk of time in between birth and NEC onset, and the one event that happens for almost every single one of these babies between birth and NEC diagnosis is feeding. So we wanted to look at feeding and see if there would be a modifiable risk factor that could be used or altered to stratify between the two groups of NEC. And feeding in the NICU, as many of you probably know better than I do, seems to be a balancing act between the want for neonatal weight gain and the risks associated with working with an immature and largely underdeveloped gastrointestinal system. Historically, the literature has proven over and over again that maternal breast milk does the best for babies in terms of NEC prevalence, NEC outcomes, and overall morbidity and mortality, followed by donor breast milk, followed by formula. And historically, fortification has always been believed to carry somewhat of a higher risk of NEC, even though it can be very helpful in increasing our caloric density and bridging the gap between what we're able to give these babies in human milk and what their actual caloric needs are. Or recently, the realm of fortification has been contested, as recent meta-analyses have shown that there really isn't a very great correlation between fortification and NEC prevalence. And moreover, there's contention whether human-based milk fortifiers or bovine-based milk fortification could play a role in NEC or NEC mortality. So we wanted to look at nutrition and specifically fortification. So what we did, we used Perinatal Information Network, or PINS, to identify cases of NEC at our institution over a 10-year period. 149 of these cases had nutritional data available. So we had a record of what the baby was eating just prior to NEC onset. We ended up using the single most recent feed prior to NEC diagnosis in order to characterize each baby's nutrition categorically. between maternal breast milk, donor breast milk, and formula, of course, with fortification status accounted for within the human milk groups. And I do want to note that fortification at our institution is a liquid bovine-based HMF, so that was standard for all of these babies, and also that these groups were not mutually exclusive. So many babies are receiving as much maternal milk as available and then supplemented with donor or formula. So that's why some of the numbers later don't add up to completely 100%. It's because babies could be in more than one category. We stratified based on patient outcome. Again, medical NEC was any NEC that resolved with medical treatment, and surgical NEC was any NEC that later was taken to the OR due to NEC, or died even before they were taken to the OR. We assessed binary outcomes with a significance of 0.05, and then of course wanted to look for any confounding variables. What we found was really interesting. It was actually the exact opposite of what we thought we were going to see, which tends to happen. We found that the intake of any fortified human milk in that feed just prior to NEC onset was actually associated with a lower proportion of surgical NEC, that is, NEC that led to surgery or death, and a higher proportion of medically responsive NEC. And this was statistically significant when we compared it to any non-fortified human milk, so non-fortified donor or maternal milk. We also found that fortified maternal milk had the lowest overall prevalence of surgical NEC outcomes, and was statistically lower than all other categories combined. In this cohort, maternal milk was associated with less surgical NEC and more medical NEC, although this was not quite significant for us. And we actually did not see any significant difference between formula and human milk in this cohort, although our group receiving only formula was pretty small, so we think that's probably why. So just to focus in on that top finding, the table that was at the very top of that last table, showing that fortified human milk intake was associated with less surgical and more medical NEC than any non-fortified human milk. We originally postulated, okay, probably our babies that are a little bit older or a higher day of life are probably more likely to be fortified and also more likely to respond better to NEC treatment. So what we did is we corrected for chronological age and birth weight, which, as you can see, drive our fortification policies, and our significance remained at 0.01. So even with correcting for age and birth weight, those babies who were receiving fortification were still having better NEC outcomes. I also want to point out this is a completely NEC population. We don't account for non-NEC babies in this group. So it's possible that fortification could be contributing to the pathology of medical NEC and not surgical NEC, and that's why we're seeing this illusion. And it also could be that the decision to clinically remove or withhold fortification is itself a risk factor for gastrointestinal immaturity and a higher risk for severe NEC outcomes. And I also want to point out, if you look at our feeding protocol, which I know is kind of small, but the y-axis is the baby's birth weight and the x-axis is day of life, with that darker blue being the time that we start adding fortification. Based on our guidelines, we're hoping to have every baby fortified by day 7 of feeding, even our tiniest babies who are born at less than 1,000 grams. And if you compare that to our cohort, the average day of life on which NEC occurred was 18, with interquartile ranges of 9 to 31, but only 61% of our babies were being fortified at that time, suggesting that a lot of our cases are falling off of this feeding protocol. So if you look at this visual depiction, on the left we have the non-fortified group, and on the right we have the fortified group, with age sort of from the back of the room forwards, if you will, and then birth weight being lowest towards the ground of the box and higher as you come up. You can see that in general, our babies who are older and bigger did a little bit better in terms of having more of those blue or medically responsive outcomes. But even in our cases of really small and young babies, shifting them or keeping them in that non-fortified group on the left seems to make them more likely to have that negative outcome of surgery or death. So in conclusion, we saw a higher use of fortification in our medical NEC cohort. And we also found that fortified maternal milk use was associated with the lowest possible proportion of severe NEC as compared to all other nutrition categories studied. Again, we postulate that the clinical decision to remove or withhold fortification based on GI immaturity or feeding intolerance could itself be a risk factor, suggesting that this baby could be headed towards severe surgical NEC. But we also suggest that early human milk fortification and better adherence to our feeding protocols could be key to reducing the deaths and surgery that we see due to NEC. And you can read more about everything I just talked about and more about our methods and discussion that I wasn't able to get to today at our paper that actually just came out in Journal of Perinatology. And I'm happy to take any questions at my email or in the break. Thank you guys for your attention.